everyone, and welcome to It's Taboo, Let's Talk. This week's conversation is about cultural competence and health equity in communities of color. Brought to you by Missy. Wait, is it this way? Yep, this way. Missy, live with Missy. Yay. And we also have some great support as well from Amoy's Barnes office, aka Amoy. We also have from 5 Before 5 Foundation, as well as Health Equity for Parents. So before I tell you a little bit more about what we're going to do, I am going to bring up our executive director, Sophia Abdulkawi. Hello, Sophia.
Hi, everyone, and welcome to our It's Taboo, Let's Talk. Today we're going to be talking about health equity and competence in our communities of color. So we welcome everyone to our talk, and hopefully we can learn something and help each other out. Have a good one. Enjoy.
So wait, before you go, because that was a little short for me. I need a little bit more information. I think the audience does too. Why have cultural competency in communities of color? Why have health equity? Why combine all those things into one event? What inspired that idea? Would you mind telling the audience?
Okay, so especially since COVID has started, a lot of people have come up to me and asking me questions and making comments about certain things that have been happening where they feel like they weren't getting their medical care taken care of because of certain circumstances, or even with the idea of the vaccine rollout, that many people were saying that, communities of colors were kind of being put on the back seat. And based on other experiences that I've seen, and also people feeling that, people are not culturally competent when they're providing care for them, whether it's for diabetic care or any other types of care, people are not really, or should I say care providers or people in the healthcare industry have an inability to understand some of their needs, or even inability to care for them in the way that they need to be cared for, and not just, oh, you're a disease process. So I spoke with a couple of my colleagues here on Staten Island. Our community partners were more than willing to come in and talk a little bit about their shared experiences, as well as maybe some solutions to some of the inequities that we have here on Staten Island involving healthcare and cultural competence.
Okay, thank you so much. It's always good to know how events start, right? Because sometimes events pop up, but we don't know where it was inspired from. So thank you much for letting us know and telling us that, Sophia. So I'll probably see you more towards the end of today's event, but thank you so much. Okay. All right. So I am going to bring up our facilitator, Cheyenne Clarity. Hello, Cheyenne.
Hi, Naja. How are you?
I am good. How are you? So I am going to leave the screen and leave this lovely lady to my left, your right, to talk to you guys about cultural competency, what that means, with a lovely PowerPoint presentation, and trust and believe it's interesting. Go ahead.
So, Naja, really quickly, are we going to be providing the opening question or introduction for our lovely panelists?
Yes, of course. Do you want me to introduce them, or would you like to introduce them?
Just introduce them really quickly, and then just provide the opening question, at least before we kind of get that start with the presentation. At least we can connect all of it together.
Not a problem. So you're not going to see their faces right now, but you'll see them later. So I have a long list of amazing people here. So we have Tanisha Franks, we have Heather Butts, we have Minister Dale Smith, as well as Amoy Barnes. We have Sadiqa Addy, as well as Dr. Raymond Brock Murray. Wow, I almost messed your name up. I am so sorry, man. My tongue got tied. So we have a couple of opening questions that will be answered by the panelists later on. So the opening questions are: how does your upbringing affect your biases toward other groups of people? 2, when being trained for the jobs and professions you're in, do you think the system is biased? Why or why not? How can cultural competence be effective in policy making? 4, what does cultural competence look like in education? 5, how can we use cultural competence to improve one's attitudes towards overall health? And as well, how are we contributing to the status quo? That status quo. Recent studies have also shown that the risk of infection in Black and Brown communities is higher in comparison to other groups. Do you believe your community is experiencing these issues? And the final question, what are the differences in our understanding of health inequity, mental health, etc., from your generations as well as younger groups? So I think I have told them a handful. I think they're tired of hearing my voice. I think they need a fresh voice to hear. So I'm going to pass it off to you. Okay, Cheyenne?
Okay, thank you.
All right.
Alrighty, hi everyone. So hope you're all well. My name is Cheyenne Clardy. I am the executive assistant for Muslim Sisters of Staten Island, but I also have been doing a lot of work regarding cultural competence as well as the mental health stigma. So my presentation is going to be talking about a number of points, which does indeed involve health equity. And let's get to it. So I would like to warn you all, this is a presentation that I have done 2 years ago at Fordham University's Behavioral Science Conference. So decided to at least make this open to the public because everyone should learn about it. So first thing is, does anyone know what cultural competence is? So to put it in simple words, it basically means it's our ability to understand, communicate, and effectively interact with people across cultures. So basically what it means is how are we aware of our world around us, our worldview, and how can we compare others in this case? So let's just say myself as a Black woman in the US, how does my reality of me being a Black woman compare to the life and worldview of someone, let's just say from England, or someone from, was it Lesotho, or, so on and so forth. So the beginning of this slide is to combat the stigma, is to challenge our understanding of mental health and those around us. Let's go to the next slide. So the objectives for this PowerPoint is pretty much talking about our demographics, how does that and our experience handle our treatment with mental health, talking about the mental health stigma across cultures, as well as our own problems with accessing mental health resources. What does it mean to be culturally competent as an individual, and in how to be cultural and ethically competent in the profession? So fair reminder, when anyone is in a helping profession, it is crucial that we do not harm those that we're working with as well as ourselves. So that is where the ethics does come in. Next slide. So culture, demographics, and mental health. So the human identity is an array of things. So whether it comes from our sex, our gender expression, religion, spirituality, our socioeconomic status, immigration, so basically our citizenship status, our country of origin, the list goes on. So this list here is pretty much explaining how lengthy it is where we can talk about our identity. And just to give, like, I guess, an image, this pretty much shows how much everything around us, as far as what makes us us, plays a role in society. So us, whether if we are able or disabled, if our immigration status, our spirituality, and like I mentioned in the last slide, all this does pertain how our society views us as people, and how does that affect us? Okay, so next slide. Now here is the 2018 U.S. Census. You see that the majority of the population, about 76.5%, is Caucasian, so white American. And basically, as you go further down, Black Americans is 13%, Asians is 5.9%, Hispanic Latino is 18%, American Indian, Alaska Native, or Nihil, is 1.3%. Hawaiian Pacific Islanders 0.2, and two or other races is 2.7. What this shows is that we, as far as if you are not of the Caucasian class, we are part of the minority here according to the census and societally. Okay, next slide. Next slide. So in the US, this is just showing all of the top mental illnesses that we have in the US. Major depression is 7.2% or 17 million. So out of the 330 million people in the US, that those numbers is definitely different now, but 17.7 million people have suffered from major depression episodes. Schizophrenia, although less than 1% of the population, is 1.5. Bipolar, anxiety, PTSD, OCD, borderline personality are one of the most common disorders and mental health disorders that we do have in the US. Now, mind you, this is strictly within the US, although the original presentation did have global statistics. The next set is that 11.3% of the US adults have no insurance coverage in 2018. Now, I would like you to be mindful, how does this look with this pandemic? With so many people losing their jobs, many of their jobs gave them insurance. So that does tie into one's ability to receive care. 60% of US counties do not have a single practicing psychiatrist. And last but not least, about 50.6% of youth between the ages of 6 to 17 with major health disorders receive treatment, which isn't bad, but could be better. All right, on to the next slide. Now onwards to the demographics. So as we see here that 10% of African Americans or those of African descent are likely to experience psychological distress. Now, a lot of this has to do with socioeconomic class and disparities. So that does contribute to our inability to seek help. Many, about 30% African American adults with mental illnesses do receive treatment. However, due to the history of medical exploitation and societal systemic issues that we do have in the US, there has been a lot of traits or patterns of prejudice and discrimination in our healthcare system, which does prevent people or make them more reluctant to seek help. Also, with the lack of cultural competence by health professionals does increase the likeliness of them continuing to seek treatment. Also like to be mindful that about 11% in 2017 had no health insurance, which does not help. All right, so next is the Asian Americans. So about 19 million people in the US identify as Asian American or Pacific Islander. About 13% of them were diagnosed with mental illnesses that past year. So this, I would like to say around this statistic was around 2019 at this time. So this obviously has changed. But they are 3 times less likely to seek mental health services than other Americans. And here are one of the main reasons. One is language barriers, which we would mention in the Latino population. They are prone to avoid health services due to acknowledging the disorder and fear of bringing shame to the family. A lot of this is a cultural issue in terms of admitting. So this is a generational and cultural issue here, but also the model minority myth. So you've probably have heard of that term at some point, whether in passing or in videos. For those who do not know what it is, the model minority myth is mainly for those who are Asian Americans. This is a stereotype that is inaccurately viewing this group specifically as successfully integrating into mainstream culture and overcoming challenges such as racial biases. Not only does this neglect the fact that this group in particular is also suffering from many issues, for example, poverty. There are high rates of poverty in the Asian American community, and this goes across East Asian, Southeast Asian, South Asian, so on. So this is just generalizing here. The model minority myth is harmful for them in terms of other groups of color, as well as dealing with the system that we do have here. Okay. Next is the Hispanic and Latinos. About 19% of Latinos in 2017 had no form of insurance. The most common disorders is generalized anxiety disorder, major depression, PTSD, substance abuse, and suicide. Although the population of Latinos seeking treatment is higher in comparison to our Asian and Black counterparts, there are issues with language barriers, which actually causes issues with misdiagnosing disorders and the inability to seek resources. Now, ang alam do have a saying called "La ropa sucia se lava en la casa," which is "Do not air your dirty laundry in public." There unfortunately do have some groups of dissent that do often hide or find it shameful that people are in their family are suffering from mental illnesses. Okay, next. Now, next is we're not forgetting our Nihil population, the Native Americans. Suicide was the second leading cause for Native Americans and Alaska Natives between the ages of 10 and 34 in 2017. Suicide was 20% higher than non Hispanic whites. Now, unfortunately, due to the fact that they're not only less likely to seek help in comparison to Caucasian counterparts, they also do suffer from high rates of substance abuse, whether it includes alcohol, cigarettes, marijuana, etc. Unfortunately, this population does suffer a lot of homicides and suicides, as well as violent deaths and regarding their population. So next, I would like to note that the disabilities and other groups, as well as the LGBTQ community, are separate in this case due to the fact that this is where the concept of human identity does play a role and how people are perceived, as well as how and when they do obtain treatment, if they do at all. So in the population, about 61 million people do have a disability. This is limitations, whether if it is visible, whether if it's a physical disability, or invisible, whether if it's speech, learning, and the list goes on. Now in 2018, about 17.4 million or 32.9% of adults with disabilities have experienced consistent mental distress. Now, what they mean by consistent is that within the month, about 30 days, that they have experienced at least 14 days of mentally unhealthy days, which sounds pretty intense when this is the majority, more than half of the month that you are going through this. Now, 25 to 40% of people with learning disabilities experience mental health problems. Now, though I do not have a lot of statistics across the entire spectrum, there's two specific ones where young people were 30 times more likely, if they were on the autism spectrum, were likely than others to have emotional and conduct disorders. Now, those with Down syndrome are at higher risk of having dementia with an onset of 30 to 40 years younger than our general population. What this means that a lot of people who often suffer from dementia tend to have it at least within their 50s and older. Now, they're saying that those with Down syndrome are of a higher rate to get it much earlier, is what they're saying. Okay, so the next slide. Next is the LGBTQ population. They are unfortunately at risk for not only suicidal thoughts, attempts, as well as violence forced upon them. High school students, so check your high schoolers and make sure that they are okay and well supported. Who identify as lesbian, gay, or bisexual were 5 times likely to attempt suicide compared to their heterosexual or straight peers. 48% of all transgender adults report that they have considered suicide within the last 12 months compared to the 4% of the overall US population. Now imagine how this looked for those who are people of color. Now, so for that group in particular, those who are non-white from this community are higher prone to homelessness, incarceration, and violence. Now, I'd like to have a fair reminder that one of the things that we do talk about is poverty. The LGBTQ community is unfortunately prone to poverty, homelessness, and which often leads to some groups going towards sex work. The most vulnerable population being Black and Latino, so Black and Brown trans women, who often have to resort to such matters. And since they are Black or Brown, trans, and sex workers, they're less likely to be found or to be taken seriously. Okay, so next slide. So next set of themes is mental health, mental health, illness, and the stigma. So about 2 years ago, I had done a whole anonymous survey just for the sake of this presentation. Just, basically everything I've talked about up until this point, just asking what are your views on mental health, your awareness of what it might be like for other groups, age, the list goes on. So this is kind of getting to know you in an anonymous way, but how has the idea of the mental health stigma affected you personally? Now, the overall themes here, you can go on to the next slide, is basically mental health is not taken seriously. In most countries, they're either being forced into seeking or being placed in an institution. Unfortunately, the US has a long history of abuse in a lot of, of mental institutions. If you're going on a spiritual belief in demons, jinn, and the Quran, witchcraft, etc. Now, for those who have probably have admitted or may have thought you've had some mental disturbances, depression, even anxiety, a lot of us have probably heard, it's in your head or you're just crazy. That is unfortunately harmful for those who are actually legitimately trying to reach out and to seek help. Now, the family environment and also social environments have shaped our or their willingness or unwillingness to seek help. And unfortunately, you have the stigma of psychiatric medication, like I had mentioned before. Our ability to seek resources and language barriers are also the underlying common issues that we've had. So the next part is issuing accessing mental health care. So this is where we're going to be talking about those who have been insured and even what's going on within the profession. So throughout the US, most states are either providing inadequate or scarce mental health services. A lot of this has to deal with the size, the geography, political affiliation to their policies. So depending on the type of state or an area that you're living in, one's policies does affect their ability to actually have properly funded resources for mental health care services or having basically virtually none at all. 17% or about 7.5 million adults with mental illnesses have remained uninsured. Some have actually were unable to seek treatment or had to stop doing treatment because the report had met that they had not met their needs. Lastly, 84% of the population that have experienced symptoms to their first visit spend most of it not really recognizing their symptoms. So, in a lot of cases, not a lot of people are actually actively paying attention to those symptoms, let alone realizing that this might be something such as a mental disturbance. Okay, so the next slide is and barriers in seeking help. So about about 1 in 5 adults with mental illnesses reported that they can get the treatment they need. That is not that great, but obviously 1 out of 5 is better than 1 out of 100. So a lot of them have often suffer from lack of insurance, or basically they're underinsured or not insured at all. In a lot of cases, they've lacked available treatment from providers. There's also lack of availability for treatment types, whether if it's inpatient, individual, or intense community services. Also, there is the issue of those who are unable to maintain it due to co-pays, uncovered treatment types, or providers are just simply not taking the insurance. So all of these are factors as to why people may want to seek help, but they can't afford it, or those who are unable to seek help and choose not to. Alrighty, so next is with people with disabilities. Now, this is important because 23% of the adults with disabilities were not able to see their doctor due to costs and inadequate insurance coverage. Unfortunately, this group, when they have both disabilities and mental health problems, they're 2.5 to 7% of a higher rate of facing issues when seeking treatment. Now, unfortunately, we already know that, especially with the last administration, they basically have spent a lot of time wiping away a lot of rights, not just rights, but also policies that were able to help the marginalized populations. So you can only imagine how things are like right now for people right now, especially for those who are abled and disabled bodies. Right. So now we're covering our youth. 6 in 10 of our youth who have depression or at risk suicidal thoughts do not get the treatment needed to support them. Roughly 60% or 64% of the youth with mental disorder or major depression did not receive any mental health treatment, though some of them do have consistent treatments. Many of them were not able to, many of them that were under private insurance did not cover mental or emotional problems. So here is the consistent issue of the fact that those that are the insurances that are provided or given to anyone has often had issues where these things were not being covered at all, which means it's out of pocket. And let's just be honest that it's very expensive. So next is our military population. In 2014, a study done by JAMA, or JAMA is a psychiatric medical journal that's done by the American Medical Association. I talked about almost 1 in 4 active duty members have shown signs of mental health conditions. When you compare the military vets in comparison to civilians, they are 15 times more likely to have PTSD. A lot of this has to do with being on the front lines, sexual assault, as well as plenty of other issues that does go on within that population. Another thing is depression being 5 times more likely and traumatic brain injury. Now, unfortunately, last year, according to this article, suicide rates among veterans had increased. So this means, and in previous years, although it was at 20%, which is still fairly disturbing, they're noticing an increase in those suicides. Now, the shortage of mental health professionals. So mental health professionals do include psychologists, social workers, nurses that are able to specialize in mental health care, counselors, the list goes on. Unfortunately, there's not enough to handle the population at hand, especially during the time of COVID. So nationally, for one provider, one healthcare provider, specifically in the mental health field, is for about 529 people. So those 529 people are basically going to that one provider. Now, approximately 8,300 child psychiatrists across the country are compared to over 15 million youths with mental health disorders. So it's absolutely disproportionate where there's a lot of people that are in need of help, but not enough people to be able to tend to their needs. Now, 4,000 plus areas that deal with mental health professional shortages have to travel long hours. And there's also the issue with the reimbursement. Now, for this chart here, this is basically all the states here talking about for every one provider, there is a certain number of people. So in the state of Massachusetts, which had the least number, for every one provider, there was 200 patients or people that were in need in that state. Now, the worst one of it all was Alabama, which had for one provider, 1,200 patients or people that were in need of help. So this comes to show that we're not doing too hot as far as handling the care, as well as having enough bodies to upkeep the needs that everyone has. Now, we need to talk about the healthcare providers during COVID-19 because this last year from 2020 up until now has been absolutely detrimental to all of our healthcare staff, though that there currently are going through burnout. So due to shortage of personnel, there has been an increase in people going through physical, psychological, and emotional distress. Now, according to the Mental Health America, they had actually done a study on 1,119 healthcare workers. The majority of them had often talked about experiencing stress, anxiety, frustrations, reported exhaustion, and feeling overwhelmed. Now, unfortunately, 39% of healthcare workers or healthcare professionals said that they are not given adequate support. But this makes it even more painful is that the nurses had a higher rate of not feeling emotional support, which was near 50%. So just imagine what they're going through while having to deal with the brunt of COVID-19, as well as the influx of health issues that are coming up. Okay, so all countries can be thought of as a developing countries in the context of mental health. On a global scale, we're doing horribly. Though there have been improvements, it's unfortunate that the concept of mental health and illness is still a discussion that needs to be talked about and seen as health. So our next slide will be cultural competence and the profession as well as the individual. So this is talking about profession and as well as us as people. Now, there's a saying is to become ethically competent is to become culturally competent. So pretty much what I'm going to be pretty much explaining is when dealing with with us dealing with ethics and tending to people, we need to be fully aware of how our experiences are taking a role in our situation. Now, based off of the research when talking about is that we do need to have where we need to be challenging of our biases. We do need to be thoroughly trained on what it means to interact with other cultures, which means that minor things, well as language and also interpretation, can lead to improper diagnoses, as well as being able to willingly care for other people. So, just to quickly go over the slide here, I'm just going to go towards the end. One of the things that I did also promote was the concept of using spirituality, religion, as well as community caretakers, as well as individuals in our community, to simply work with others in the psychological profession. So those who are in the mental health care, those who are in policies, to work with those to see how we're able to actually combat the stigma. So you can actually go towards the end for mental health literacy, because this is a bit long, so I'm going to cut it short. So the point is that there are plenty of things that we need to do as far as within policy, as well as within handling ourselves and the people around us. So this also does include understanding that how harmful our words are to others within our friends or family as to what we're saying actually does reinforce the status quo of our inability to understand the mental health stigma. So I'm going to conclude the presentation. So thank you for listening. And I would like to bring Naja onto the floor.
Hello, Cheyenne. Thank you for that informative PowerPoint. That was a lot of information that I feel like both myself and everyone else is going to have to soak in like a sponge and let it like settle in overnight, because that was a lot. And I feel like I've become like a brainiac with the amount of information I just gained. So I am also going to bring up our lovely panelists one at a time, because, you know, we want to see their faces too. So the first person I'm bringing up is Tanisha Franks. Hello, hello. Next, I am bringing up Heather Butts. Hello, Heather. Let me move this little. All right, we have Minister Dale Smith on board. Hello, Minister Dale. We have the lovely Amoy Barnes coming on. Hello, Amoy. We also have Sadiqa Addy. Oh, wow. And we also have Dr. Raymond Brock Murray. Hello, assalamu alaikum. So there were a couple of questions that I mentioned at the beginning, right? You know, like ages ago, right? So I'm going to be asking you guys a couple of questions. Anyone can answer at a time. However, I probably will pick one at a time to answer, just so that way no one's talking over each other, because it's kind of hard in the virtual world, right? So the first question that we had kind of towards the beginning was, how does your upbringing affect your biases towards other groups of people? And you can also chime in about anything also from the presentation that you want to add as well. So who should I pick? I am going to go with Heather Butts.
Hi everybody, how are you? So I actually am really looking forward to the comments of the other panelists with respect to this and other questions. How do your biases impact on how you see others and see yourself and so forth? So, so that's obviously a very multi-layered comment. A lot of how you see others is viewed through the lens of, how we think about ourselves and what kind of exposure we've had to others. And I almost wanted to use air quotes. I hate air quotes, but I find myself using them lately. I don't know why. But I think, right there, when we think about sort of others and people who are outside of ourselves, that's yet another issue, because when we think about people who are not not like us or different than us or don't have things in common to us, then that also sort of speaks to the distancing between us and someone who for some reason is different than us. But by the same token, we have to acknowledge that we do come from different backgrounds, and we are viewed in very different ways by society and by coworkers and by people who are not part of our family and maybe people that are part of our family. And so I think, to the extent that we can acknowledge that and start to function in a way that we acknowledge that, I think it's very important. The other thing I would just sort of say, and then I'm going to hand it off, would be, obviously, I'm a public health person. So where the rubber sort of hits the road for me with respect to this is the medical field, and how people get very different healthcare based on the otherness, or people not seeing them as entitled to the same kind of care as somebody that potentially looks like them. And so I'm looking forward to continuing this conversation to talk about medical care and the biases that can mean the difference between life and death for people in terms of not getting the care that they need because they don't look like somebody else or there's a bias there. So to be continued.
Thank you so much, Heather. Also, too, while you guys talk, please say like your accolades and stuff too. Like you can, plug yourselves a little bit. There's nothing wrong with that. So the next person that I'm gonna have speak is actually Dr. Raymond Brock Murray. If you would like to speak, and the question is, I'll repeat it. How does your upbringing affect your biases towards other groups of people?
Okay, first and foremost, thank you all for having me on today. Just a little bit about myself. Uh, I'm Dr. Ray. I have a doctorate in counseling psychology, and we actually run a foundation around providing mental health services and programming and consultation to different organizations in communities of color, and particular communities of color of faith. And so I think that this is a very good question, because I want to take the approach from kind of off the beaten path, right? So when you say the word biases, how do your biases impact the way that you look at other people? Um, Not all biases are bad. And so when we say, in terms of like just on its face, right? At face value, not all biases are bad, even though sometimes they can have negative consequences, right? Again, the sister earlier talked about being the Asian American community being the model minority, right? Where you have the idea that people think highly of you as an ethnicity. Well, that might necessarily on its face be bad, right? Because I think all of us as people of color and other different minority identifications, we want people to see our value. The problem is that we're kind of you become an object as opposed to an individual, and you're not necessarily a being. And so when you talk about a person having those same biases, I think that when you say bias can be something that's negative, even sometimes biases can be something that's positive, that especially we as minorities project onto other people. We see value in other people that we don't see in our own selves. So we treat those people with a value that we don't treat our own selves. And so when you say, how does it affect how we see other people? I just wanted to approach it from that perspective, because I find myself, especially having worked, at college counseling centers, you get a lot of students of color, you get a lot of people from different minority groups, where they're looking at the majority groups or groups with privilege, and it's more of a reflection of how they don't see themselves. And I don't want that to get lost. I'm sure everybody has comments along, those same lines, but it's not always bad the way that we look at other people. I think the reflection from how we look at other people can necessarily be bad. Um, and sometimes a lot of that is like our own internalized self-consciousness, right? So the way we're looking at other people can be the consequence of negative experiences we've had with that group, the consequence of just messages we're hearing about people from that group, but then also it can largely be a reflection of things that we don't see or don't like within our own selves, that we're constantly finding as things of value in other people, causing us to overlook those same attributes of value that are within ourselves that we've been taught to overlook over time. Sorry, I hope I didn't
No, that was
kind of
good.
get too
Thank you.
philosophical here, but
No, thank you so much, Dr. Raymond Brock Murray. That was, you guys, all this knowledge. I feel like I'm the one on the other side watching everything and learning instead of being like a mediator. Thank you so much. And then I'll bring it on to one more person before we change to the next question. I would like to ask Tanisha Franks, how does your upbringing affect your biases towards other groups of people?
So to echo some of the prior comments, we know that biases are a condition of being a human being. So everyone actually has biases. And what one of the major factors of developing personal biases is your upbringing. You're going to definitely project the things that you have experienced. And as a young person, those formative years are going to construct your beliefs about people and environments.
Thank you so much. So on to next. Okay. So the next question we have, I think there's an echo. Am I echoing? Can everyone mute really quick? Echoing real quick? I'm sorry. Hello, hello? Okay, maybe someone echoes me. So the next question is, when being trained for the jobs and professions you are in, do you think the system is biased? Why? So I already saw an eye roll from Siddiqa, so I'm gonna bring it over to Siddiqa Addy. And if you would like to just explain like who you are, like your background and stuff like that before you answer the question, please. Oh wait, you're still muted.
Okay, here we go. So thank you guys for having me on here. It's nice to meet my fellow panelists. I've known many of you guys for a few years now. So I'm a registered nurse, obtaining my master's and hopefully my doctorates in nurse practitioner. And with the question saying, you know, when being trained for jobs and professions, do you think the system is biased? Unfortunately, yes. It's biased, one, against women, and two, against race. You know, a Middle Eastern background, born and raised in the United States, Muslim Arab American. When they see my name Siddiqa, they think of me as a completely different person. And unfortunately, in my background of applying to many jobs, people just don't want to have anything to do with me when I submit my resume because they see my name and they see it as a complicated name to pronounce. So they see Siddiqa and they say, oh, okay, I'd rather have someone with an easier name because that's going to make it better for my business or my corporation. And then when they see me, they ask me questions about where I come from and am I new to the United States? And when I speak, and I'm like, no, I'm born and raised here, second generation. So it's not because my name is so complicated. Doesn't mean I'm, you know, someone that's not from here, but I am from here. And unfortunately, hopefully the system will change. Seeing more women in leadership roles and more people of color in those roles, that will make a difference.
Thank you so much, Siddiqa. And also to add, for those who don't know what your profession is and may not be able to see the RN attached and don't know what the RN means, it's a registered nurse. So, you know, we got some medical people in the house.
Yeah.
So the next person I would like to ask this question would be Minister Dale Smith. So when being trained for the job and profession you are in, do you think the system is biased and why?
Good evening to everybody. Phenomenal presentation. I want to say to my sister, thank you. Mister, you guys are a phenomenal organization. Let me first say that. Minister Dale Smith, 20 years military retired, United States Coast Guard. I've been in the human service field since 1998. My bachelor's is in liberal arts, criminal justice focus. I've been working with young people in non-secure detention and group homes. I'm currently now working in leadership development and youth build program, as well as anger management, nationally certified in anger management, as well as working, and was a licensed Baptist minister. So to answer your question, Absolutely, it's a Eurocentric world. So we live in a Eurocentric world, and first and foremost, we have to understand it from that concept. But I would say for me, what I teach my students a lot of times, though I may be taught this way and be trained, I utilize it. I think of how can I take this information and bring it back to my community and make it better. So I use it as a tool for uplifting. So that's what I use it for. So when the young lady was talking about microaggressions that she discovered by building history, we all can know about microaggressions in our society we're going through. So even sometimes when we're training, people think less of us than. But also I use this as a platform to uplift and as a challenge, as obstacles. But yeah, absolutely. We definitely know that there's no system that's not Eurocentric. All systems are Eurocentric and it's taught that way. But we understand that. We have to understand how the obstacles, and also we have to have supplemental education to deal with that. So I'm always solution driven. Solution driven is also to have conversations like this that can turn to something else, perhaps an organization, to deal with mental health, to deal with all the topics we're talking about tonight, and not just let it go. It's a great conversation. You guys are powerful people, but take this conversation and make it a more permanent level of focus in our community to make it more powerful.
Thank you so much, Minister Dill. And you all had some really good points. Trust and believe. I will repeat some of them. About one, the issues with the name, like Sadiqa was talking about, how it's kind of saw as like, oh, you have a hard name, next, or kind of how we do technically live in a Eurocentric world, or a world wrapped around that concept of Eurocentricity. And also to just, you guys have a lot of points, trust me. I wrote them all down. I'm going to say them. So I want to, because we have a lot of questions, so I want to make sure I give you all opportunities to speak and also go through each question. So the next question we have is, how can cultural competence be effective in policymaking? I'm looking at you, Amoy, because I know Amoy has a lot to say about certain things. So I'm going to hand it off to Amoy Barnes.
Well, thank you so much once again, as always, to Missy, for all the amazing work that you guys do. And Naja, you are like an amazing powerhouse of a young woman. So I just want to just always give a big shout out to you. Snap, snap, snap it up. And thank you to all the amazing panelists. Everybody here is so fantastic. Minister Dale, Sadiq, I said your name wrong. Oh my God. As we just talked about it.
Sadiqa, yeah.
But it's not that hard, though. It really isn't that hard. Tanisha, Heather, and the doctor, thank you all. Cultural competence, be effective in policymaking. First and foremost, if anybody wants to be in a position of policymaking, it's extremely important for them to recognize what they don't know. Because in recognizing what you don't know and what you don't understand, then what you're going to do is seek the help and assistance of people in those areas and fields of specialty, right? Everybody needs to recognize that they do not know everything. But what you want to do is you want to surround yourself with people who do know and who do have that area of expertise. So when we talk about cultural competency, I think the first thing that people have to remember to do is recognize where they might fall short. Because we can't talk about cultural competency and people not recognizing that you are lacking in cultural competence. And that all too often, in my opinion, seems to be the big issue sometimes when having those discussions around cultural competence, people making that hard realization that you are lacking. But just because you are lacking in an area of field of knowing about other people doesn't mean that you still can't learn, right? Doesn't mean that you still can't understand. And so in learning and understanding by surrounding yourself with those areas and in that field and being open-minded and listening is how you can do better at developing policies that effectively support the needs of everybody, and understanding that people are not a monolith, right? Like earlier you talked about how did your biases as you growing up affect the way you look at things or treat people and things of that nature. I'm Jamaican, right? And being Caribbean of background and heritage, we don't consider ourselves African American. Our history is different. Our things are different. Nobody is a monolith. We all come from our own background, our own basis, our own experiences. And so effectively, people have to recognize that we all have some form of cultural competencies, some form of work to do. And in recognizing that we all have some work to do, then we can have that real conversation and actually communicate as a community, as a collective, when we're building out policies that are actually truly effective, because we're bringing other people into that conversation and we're not thinking that we know the do all and end all and everything about other people.
Wow, the power. Uh, no, that's very true, because like sometimes we have to like look within ourselves, right, or look within our close vicinity when it comes down to where we may be lacking, because we love to like point fingers, right? Like, you're not culturally competent, you're not culturally competent, you're this, you're that, you're this, you're that. And was it like, you know, if you're fingers pointing at someone, there's like four are pointing back, or whatever the saying is. I'm probably getting it wrong, but you know, and it's true, like we're always constantly looking at everyone else, but we forget that we have mirrors, right? And we have to also look at ourselves to make sure that we aren't displaying the very thing that we're being persecuted for on a consistent or daily basis. So thank you so much for that. So so some of you guys will be speaking more than once, so just so you know. So again, I want to ask, let's see, Heather, because I feel like this would be a good question for Heather. How can cultural competence be effective in policy making? You're muted.
I was saying I started talking before, just felt no need to even, you know, give a name to myself or anything. So there's that. But my name is Heather Bunce. I am a public health lawyer. I also am an assistant professor at Long Island University, and I'm the director of their honors college. And I also have an appointment at Columbia University Mailman School of Public Health, where I did my master's degree work there. And so this question is very near and dear to my heart, because obviously as a public health lawyer, I live between the intersection of law, regulations, and policies. That's the work I do. You know, before COVID, I was doing Ebola work, and I was doing 1918 flu work. That's soda bans. That's what I do. And one of the areas that I'm super interested in, obviously, is research ethics. I worked at Columbia's Institutional Review Board looking at clinical trials for 8 years. And so cultural competence, you know, in the research world is a huge deal. And I think now when we're thinking about some of the issues with COVID and the vaccines, and how we are culturally competent and understanding of people's real fears regarding their issues with the medical profession, and not basically receiving the level of cultural competence that they should have, from a policy standpoint and from a legal standpoint. It's imperative that we look to some of the laws that we have, and the policy that we have, to make sure that people of different backgrounds, different races, different ethnicities, from all diverse walks of life, really sort of are able to feel that they are part of a policy that is meant to help them, but they may not always feel as though policies in the past have. I'm looking at you, Tuskegee. So I think we need to be very aware that policies in the past have been very racially, ethnically, gender not fair. And to the extent that we look at those in power from a legislative perspective, from a policy perspective, and from an elected official perspective, in terms of the laws that they're putting in place, the ordinances and so forth, then that's kind of critical to the cultural competence of effective policymaking.
Wow, Heather, you guys are so powerful. No, but you brought up a really good point, right? Like where a lot of people do feel like a lot of the policies don't pertain to them, right? Or they're kind of left out of it.
Well, I would just say that I think people unfortunately think they very much pertain to them. there's an old-timey 1905 case called Jacobson v. Massachusetts about vaccinations, and a man named Jacobson, who was from Sweden, actually, and did not want to get vaccinated, and basically made the case that, look, I'm from Sweden, the vaccine there was horrible, my culture doesn't really, we're not about it. And he was put in jail. So, I mean, we have a history of kind of not really recognizing people's voices when they say a policy may be in place for everybody, but it doesn't actually speak to me. And I think that's something that we really need to think about in terms of our laws and our regulations. Do they actually speak to people, and do people hear it? And do they really say something to individuals? And some of them don't.
No, that's very true.
No, that's very true.
Oh wait,
yeah, I definitely agree on that. Just really quickly, this kind of just hearing what you had to say, Heather, kind of reminded me of the medical exploitation of basically of people of color, like whether it was talking about birth control for women in Puerto Rico, a lot of them were being sterilized. You had this situation with Tuskegee, for example. You have, James Marion Sims, becoming the father of gynecology off of using Black slaves, female slaves, just to make these achievements. And even when you look at COVID right now, when you see the reluctance of people of color, especially Black and brown people, when they're hesitating in terms of getting the vaccine due to just the trauma of what has gone on in policy, and also just kind of going through the moments. It's like the whole idea of cultural competence and equity. Also, we need to focus on those biases, but also just what was the result of our past circumstances, especially in policy.
Thank you so much for chiming in and adding that on, because that is true, right? We had an event last week, actually, hilariously enough, talking about demystifying COVID, vaccine talk, as well as like communities of color and our experiences and relationship with that. So if you want to check our Facebook and YouTube, it's there. So moving on to the next question. Right? What does cultural competence look like in education? And I really want to ask this to Tanisha. So what does cultural competence look like in education?
In education, cultural competence requires that practitioners engage in self-reflection about their own cultural identity, as well as the cultural identity of their students and the families that they serve. It also demands respect for others. In culturally competent education settings, there are going to be accommodations for different learning styles and abilities. Additionally, culturally competent teaching and learning requires focused activities and intentional structured environments. And I would say, lastly, one would expect to see intellectual communication skill, intercultural communication skills in a school environment that is culturally competent. And so it's not just enough to acknowledge that different students listen to different music, or perhaps get to know the slang that young people are using. You actually have to interrogate your own biases, be willing to pull them apart, and address them, and make sure that you check them. Acknowledge that we all have them. It doesn't make you a bad person. In a society that we have all been reared in, we expect that people are, it relates to, the earlier question about upbringing. And it has all to do with the question additionally about preparation and professions. The preparation for education still has to catch up to these things. So there are folks in education environments that haven't engaged in that work in their preparation. And so they have to do it in professional learning and acknowledge that these things, not engaging in these things, are actually harmful to the very students that they are looking to positively impact I have met a lot of educators, and I don't think anybody comes into teaching to be harmful for students. But in environments that aren't culturally competent, we run the risk of doing just that.
Thank you so much. And that's true. Oh, wait. Sorry, we'll figure it out. But thank you so much, Nisha, because that's true. Like most people, when they go into professions, especially involving anything social, right? Any type of social science, with any type of education, anything involving people, the idea or the concept is that's to help people, right? To be there for people, lift people up, assist people in some type of way. So there isn't, hopefully, anyway, I mean, generalize here, like an innate thought of to harm, right? So you're not thinking of the things that you might have within yourself that may be harming other people, or maybe putting people down, or maybe, making them feel othered, because in your mind, you just think you're just doing your job, and that's just how you go about things. But that kind of just goes back to like how we were raised and the biases that we take with us through our journey, with our experiences with different people, with our families, our friends, different environments, stuff like that. So I'm going to just quickly move into the next question. So how can we use cultural competence to improve one's attitudes towards overall health? I want to ask this question to Dr. Raymond Brock Murray.
Okay. I think one of the things that's important relative to that is something that goes back to one of the questions that you mentioned earlier, right? So, in cultural competence, especially for any audience members who are listening to this, is the idea that sometimes when you're in training in graduate school, when you're out in your profession, that you got to do some of your own learning too. You got to work outside of whatever it is that you might be being taught, because some of that stuff isn't necessarily reflective of cultural competence, even if it's well meaning, right? And that you might want to go to more authoritative, more authentic resources that, you know, the school, your workplace is not taking advantage of. So, hold on. My kids are so curious to see who I'm talking to. But then after that, when you talk about changing people's attitudes toward overall health relative to like integrating cultural competence around it, number one, you have to take all of the cultural competence that you've learned through education, you've learned through professional experience, you've learned through your own life experience, and then you have to take that into the communities where those people are, because that is going to be their first encounter opportunity where they see, hey, here's somebody that either looks like me, lives like me, understands me, and gets all of the contexts that I'm coming from. And that is what begins to change a person's idea around health, because they hear someone who speaks their language talking about it, using terminology, referring to cultural experiences, community level experiences that they can identify with, and placing the health concern within the context that the people of a specific community understand. And so it's almost like a mix between book learning and life learning, and then taking all of that to actually sit down, you know, knee to knee with the people, and listen to their stories, and then reflect back to them what you're hearing as a person who's kind of studied the issue, so that they can start to wrap their minds around it more.
Thank you so much, David. Almost called you David. Where did David come from? Dr.
Know
Raymond.
she's muted. Okay.
Sorry about that. I don't know what just happened.
So,
Constant technical issues. We'll figure this out one day, even though we've been using this stuff for a year. But I do want to ask this question again, to actually Sadiqa, because we have two different spectrums of health, right? So how can you use cultural competence to improve one's attitude towards overall health?
So cultural competence, as a registered nurse and even a minority here in the United States, when you look at the word cultural competence, it's about understanding other cultures and being well aware about them. Right now in hospitals, hopefully around the world, they're educating and putting these lectures for employees in the hospital to teach the employees about religious beliefs and cultural backgrounds, because I think that will link us to these health disparities and understand patients or people in the community more. Because how could you know if I'm a woman of this color, where I come from, what my background is, what my beliefs are. As a Muslim American, you should know that, I prefer a certain gender than a clinician than someone else, or, I don't eat pork, and having that respect and respecting the boundaries. And I think if we can conquer that, then a lot of those barriers will come down. And the main one is, unfortunately, the language barrier itself, the religious barrier, and the cultural barrier.
You made some pretty good points there, Sidika, right? So like understanding someone's culture, not just say like, okay, this person's this culture, and then you like kind of be like, well, check mark, and just do whatever you want, right? Understanding to a point where you're able to accommodate, right? To make them feel comfortable, right? Because they're coming to you in your case, right? As a medical, practitioner, right? They're coming to you with all this trust, right? Like, I need your help. I think there's something wrong with me, because usually we go to you guys when there's something wrong, not when there's something right? So
understand me with no biases, basically,
Yeah, understanding with no biases, and I think that's hard for so many people. But I think once if you try, I think eventually you'll be able to get to that point where it's like, okay, you're a person, you have these things, we can work with this, and still give you the services that you need, right?
Exactly.
So next question is, how are we contributing to the status quo? Amoy, how are we contributing to the status quo?
That's an interesting question, because I mean, the status quo, how are we contributing to the status quo? I mean, to be honest, I think that I sometimes take offense to this notion of the status quo, right? Because the idea of the status quo meaning that there is a certain way of doing things, and there's a certain way of acting, and there's a certain way of being. And I've always hated the idea of there's a certain way of doing things, a certain way of acting. I mean, I think at the end of the day, I guess we all adhere to some sort of status quo, but of course interpret it in our own way. Because we all have different personalities, we all come from different places, we all come from different experiences. And no matter how hard people try, the status quo, and I always say, I can never be the status quo. As a Black woman of color, this, that, and the third, I am not status quo. So what I can be is myself, and adhere to certain ways of being or thinking or talking or whatever it might be, assimilation, I guess one can say, right? Assimilating into what society expects, right? What allows you to progress in life, what allows you to be, moving forward. But in terms of status quo, I think one has to decide what works for them. Because at the end of the day, some people are very good and cool with assimilating and going with the flow, and I guess assimilating into that status quo, and contributing to that status quo. I mean, depending on whatever level you want to talk about it as. And some people are just like throwing it out the window, and they're going to do their own thing. I think it's a term. Like I said before, it all depends on what you think the status quo is. Because my perception of the status quo might not be the same as somebody else's perception of the status quo, might not be the same as your perception, as Reverend Dale's perception, as Tanisha's perception, as Heather's perception, because it's based off of what you've grown up with, it's based off your experience, it's based off of your culture. What is the status quo for a person's culture? I had the pleasure of living in Morocco as a Peace Corps volunteer, right? And the status quo there is very different than the status quo as being a Jamaican or being African American. It's all perception, and we have to remember that once again, going back to the fact that we're not a monolith. I hope I answered the question.
It's whatever answer you give, it's okay. but that was true, right? So it's kind of like one of those trick questions that you have on tests that like make you rack your brain around, and you get mad when you got it wrong when the answer is simple. But no, yeah, like what is the status quo, right? Like what does that mean, right? You might have heard it in like those cheesy like movies as like kids, or like when you guys are kids, because I'm slightly younger.
People have called me status quo, and I'm like, I'm status quo, really?
You know, but
I'm like, really? I'm like, I don't get it. Because I'll be like,
be.
what does that mean? What does that mean?
But that's true. That's what were you saying, Minister Dale? You were saying something?
Actually, I was teasing more. She's soon to be status quo, but that's an inside joke there. but what I do want to answer this question though, if I can. I don't mean to jump ahead. Picking back what Ms. Barnes is saying, though, status quo for me is decency and order. We don't serve a God of confusion, so decency and order. I think that's universal. That with decency and order, this country should be the highest ideals. I too sing America, Langston Hughes' poem that I buried my mother to. I too sing America that regardless of my ethnic background, regardless of my pigmentation, we have a sense of decency we should aspire to. So that's the status quo. I think of the status quo. So yeah, I'm part of the status quo when it goes to that. So that way, I'm culturally competent right from the jump. I'm culturally competent because I see everybody's beauty as well as mine. I quote Dr. Karinga, the creator Kwanzaa, said, I can uplift my culture without destroying anybody else's. I think that's culturally competent. That you understand your beauty of your culture, yet you love and search for the beauty of the culture, what I think we're all saying here, search for diversity. That's where we're the highest. That's status quo. We're the highest when we're actually celebrating everybody's beauty and what they do, no matter what it is. The more I talk about Jamaican background, we're all multicultural in different ways. All of us have, if we go back to our DNA, I'm sure we find a whole lot of different people in different trees. So we're all multicultural. If we're truly going to do this thing as a human being, I think that's status quo. We should search for decency and order. I just want to say that.
So we got one that says status quo is anything and everything, and we got the other. It's like status quo is being orderly and just being a regular old good person. I like them. I personally like them both. But you said something that was like that really hit me, right? Like you can uplift your own culture without destroying others, right? And I think that really speaks true to cultural competency, right? It really speaks true to being of the awareness of other people and respecting of other people's cultures, right? You can, wave your flag around till the cows come home. You can do whatever you want, but not bring anybody else's culture down, right? Say your culture is better than anybody else's culture, right? To say that people have to be a certain way because they're from a certain culture and judge them just simply off of that, right? Because just because you can be culturally aware, right? I can be aware of someone's culture, but it doesn't necessarily equal, cultural competence, right? It doesn't mean that you're culturally, aware where you're accepting the fact that that's your culture, that's what you rock with, cool, dope, right? Instead, you might be having it where it's like, oh, that's your culture. I don't know. It's a little something else. I don't know if I can deal with that. And that makes a really big difference, like we were talking about in different professions, right? And how in different systems and how they're structured and how it overall affects the people. So thank you so much for talking about that. So our next question is, oh wait, hold on. I have a long thing and then I have a question, sorry. So there was a recent study that showed that the rates of infections in Black and Brown communities is higher in comparison to other groups. Do you believe your community is experiencing these issues? Anyone wanna chime in? I'm opening the floor. I feel like you guys are kind of chiming in your own. All right, Tanisha, go ahead.
I think that what we know to be true in America, in the US, is that when there's a crisis in the greater society, that it impacts other society, other populations in a more severe way. So at this point, if you look at the recession, the depression, it's always exasperated because our communities happen to exist in crisis when there's no crisis. And we know that that's from centuries of oppression. And, when we talk about, I'll hop back to the status quo, the status quo in the dominant culture is not kind to communities of color. And that's not opinion, that's fact, right? It's the reason why we're having this conversation, right? If it wasn't so, we would, there would be equity across lines, and we know that there's disparities in our communities, not in a positive way. So do so we knew, I am going to speak for myself, which is very important. And being culturally confident, you shouldn't really put words in other people's mouths, even though I'm looking at the panel and I know y'all know what I'm talking about. But so I will say I knew immediately, as the global pandemic started to reveal itself, that it was going to impact Black and Brown communities differently. And I had a conversation with someone talking about the pre-existing conditions, specifically in the Black community. We were watching, to go back to the spring, it was, horrible, because we were experiencing daily reports of community members and loved ones passing due to COVID. And we looked at the pre-existing conditions that exist, and it to me, it seemed like, it was like on top of that. So like diabetes, obesity, poor diet, maybe the fact that you don't have a family doctor that you regularly see, so that someone you can call is very, as we talk about disparities in healthcare, being able to pick up the phone and call your doctor is a very major thing than having to convince someone that you're sick. And so, but then I was having a conversation about the pre-existing conditions that already exist in our communities, and the person that I was speaking to brought up the care that people get. So what I was able to understand from that conversation is that whether you live and die when contracting COVID could very well have to do with the care that you get. So people's death rates are going to be impacted by how they're treated. That is the reason why it was so important in the spring in New York City to pause so that we could flatten the curve, because what we were doing was we were inundating the healthcare system and hospitals, right? And so it was having an impact on the care. But if you are a Black or Brown person, and if you've been in the hospital, if you've gone to the doctors, you may have had this experience. Again, I want to speak for myself and use the experiences that Black women have in gynecology and giving birth, and the rate of mortality for giving birth for Black women. That has to do directly with the care that we get, right? And so when we talk about the perception that Black women can tolerate higher levels of pain, and when we talk about that, so if I'm pushing the buzzer and you think I'm okay and you're not delivering, that requires you do some exploration of your biases. And if you're not aware that you have that, it can have deadly consequences. And we know this to be the case. So in terms of belief, I don't have any problem believing that that's exactly what's happening. In fact, I had been very vocal, in a tongue-in-cheek kind of way, like making a joke that I wasn't leaving the house. Like I was not putting my life in the hands of our medical system because I don't trust them, right? So what I'm doing is I'm staying in the house because I cannot afford to be in the hospital where my loved ones don't have access to me, making sure that I'm getting the proper care. And for the people that lost people, that's exactly what happened, quite honestly. So it has nothing to do with believing it. That's what happened. People had anecdotal stories to tell that, they didn't have access to their loved ones. And the notion, matter of fact, and I will stop after this. There was early on an article that came out of, gosh, I think it was Italy, but I could be making that up. I could be guessing. But there was an article that actually said, the headline was that they're actually deciding who lives or dies because there weren't enough respirators. They're actually deciding who lives or dies. And when I saw that headline, I was like, oh, bet, I'm staying in the house because I'm not leaving that decision up to you guys because I already know how that goes. So the belief in whether this is true comes from our lived experiences.
Wow. No, but that's like a lot of things that we also talked about in our last week's event, our last Taboo talk about the vaccine, right? And also this the history of medicine with people of color, right? Specifically talking about Black people. About with experimentation, we also mentioned that even before with the Tuskegee experiments, you got Henrietta, right? Like skin cells, all these different things that like add on to like the lack of trust, right? And then the things that are still going on today that still amplify kind of like the lack of trust, though there is hopeful change and there is change happening, especially as there's more and more people of color in these settings to be kind of more aware and culturally competent. But the hope is obvious for everyone to be culturally competent so that way no matter where we're going, whether it's for a toothache, whether it's for a transplant, whether it's to the post office, picking up your child from daycare, whatever the case may be, there is no fear or worry that they are going to be treated differently to the point where it affects their livelihood, right? It affects their life overall. So wow, you said so many good things. I'm taking a minute to absorb it. I'm sorry. but it speaks. Does anybody want to add anything before I move on to the next?
Yes, Sister Frank says so many profound things. I do think of one thing I do want to add. I think culturally competent. I think as a community of color, I'm gonna step out here on the limb. As a community of color, we're not pre. We always talk about post. We're about prevention. A lot of things we don't talk about prevention, and I talk about mind, body, and spirit. Even sometimes in church, I'll speak for the Christian community. A lot of times we're not pushing enough pre-care as far as health, exercise, things of that nature, things you can do other ways, prevention you can do to counter the pre-existing conditions that plague our communities. So that's a factor as well too. So I think we have to look at that within ourselves and understand. Yes, we have a lot against us. We know this, but a lot of things we could do and we need to push that, propel that, basically say okay. And sometimes. And rescue me if I'm wrong. I don't want to say this. If I'm wrong, please everybody yell at me and say I'm wrong. But I think a lot of times we don't see that as part of our culture to be healthy oriented. And that's unfortunate. I think sometimes we see this kind of like you're a special kind of person if you believe in health, where it should be, we all should embrace it. And rescue me if I'm wrong. I'm asking the panel right now. Do you agree with that, disagree with that? But I think a lot of times in our communities of color, we don't embrace it enough. We don't embrace a healthy lifestyle enough, even to a point of taking care of ourselves, dressing appropriately, winter, things of that nature, and different lifestyles. So I just want to throw that out there as well.
Oh,
thank you. Yeah, go ahead.
I think I might be frozen, but I look very pensive. So, I mean, I think that's good, I look like I'm having a deep thought. So there's that. Probably really think of ice cream or something. But in any event, I just wanted to add to the really amazing things that I just heard. One other sort of note, and it kind of does go back to what Tanisha was talking about, which is, how you entered COVID is how you are experiencing COVID. And a doctor friend of mine said that to me, and I mean, just hold on to that. It's so true. So COVID isn't making things better for anybody from a medical perspective, from a health perspective. It's not like somebody's having their best medical life in the COVID era, quite the opposite. And so if you already entered COVID and you had issues regarding diabetes and mental health and tuberculosis and pneumonia, well, guess what? That's not going to be made better by COVID. And so I think some of what you're seeing from a public health perspective, and again, I've been in public health for a long time, and if I asked somebody a year and a half ago, what is public health? I asked 10 people, I'd have gotten 9 blank looks. And now, if you ask somebody what public health is and they don't know, what rock have you been living under for a year and a half? So, people have gotten, sort of hip to what's going on here. But long before COVID showed up, people were suffering in ways that were ignored and not paid attention to. And the fact that now we are patting ourselves on the back and saying, oh, well, now people are having issues getting the vaccine and getting to a vaccine site and wearing masks and so forth. Well, where were we a year and a half ago? So I think we all have some accountability. And long after COVID is over, and there will be an endpoint, it didn't feel like it, but there will. Long after it's over, we all have some hard questions to ask of why we got here and why people and I think my community is it's beyond Staten Island or Queens. It's all of us. Why did we allow people we're all the best of us, and we should be thinking that way. And when some people have to think about how they're gonna get a ventilator when they're in the hospital, it was Italy, by the way, so well played. But how they're gonna be able to get access to a ventilator or a defibrillator or some other machine, we've lost our way. We've really lost our way. So we need to all reflect on how we can find our way back.
Thank you so much, Heather, because that's true. Like, we do need to kind of find our way back, right? Because there's a lot of different issues involved in this. Like, cultural competency could be something we could talk about like forever and a day, right? Because it's so intricate and so many systems that we're involved with on a daily basis, right? Education, justice, equity, different types of equity, everything that we kind of are interacting with, especially living in like America, where they say it's the melting pot or a salad, however dish you want to put it, it's a lot of things in one, right? And especially living in New York City, on top of that, there are so many people involved with each other all at once. Did you wanted to say something, Siddiqa, or I'm sorry?
Oh no, actually, I was just. My husband is actually right next to me, and I'm telling him how the resources also in the communities are a huge disparity. Even like Heather was saying, before COVID, people were just too afraid to go to the hospital because of a cultural background or not being helped in a certain way, or if they had a bad experience, or even not having the proper transportation. It's hard to go to a doctor's office if you don't have a car and you're going to take 2 or 3 buses and it takes you an hour to get there. There's so many things that have to do with it. And that's why, Black and Brown and Middle Eastern communities, obviously, I guess we're considered in the brown phase, where we're affected, and again, you are home, you are under also these other myths, and there also isn't people of our culture or color. There isn't many physicians. How many OBGYNs do you know that are of Black and brown?
My sister.
Give me her information. But I guess if you want to look at the statistics, how many are there available for us? Compared to the white Anglo-Saxon European, there really isn't. And even when you do go, you're like, okay, well, this person is located, but they're like 50 miles away. So that's just my 2 cents I want to put input.
But that's really great 2 cents. Oh, oh my God. That is really great 2 cents. But I know, I facetiously said my sister because she's one of a handful that I know. And, if you're, again, I think you can't discount the importance and persuasiveness of going to a doctor who looks like you, who knows your story. I'm a lawyer, and it's not the medical field, but people talk to me all the time about a professional that can sort of understand what they're going through, and you can't underestimate that. No matter how much people might want to, you really can't.
Exactly.
No, I completely, you guys did so many amazing things. Like, I'm gonna have to like get a board and like just put them all there so I can like say it to people and sound smart. Um, because and it's actually all the things you guys have been saying this whole time really kind of leads up to this last question, right? What are the differences in our understanding of health, inequity, mental health from your generation and the younger groups? I'm considering myself as a middle group between the older generation, the younger generation, because Gen Z thinks I'm old. So with that in mind, for reference, I'm 25. So I want to first point this over to Dr. Raymond Brock-Murray. You know, what are the differences in our understanding of health, inequity, mental health, all that stuff from your generations, as well as any groups that between that and groups that are younger than your group?
Well, number one, I think that I'm going to speak specifically to like psychology and mental health, right? So, especially, me being a Muslim, me being African American, I think I can kind of speak to my experience of those more than anything else. Um, I think that generationally, um, the farther down you go to the younger people, they're much more aware and much more sophisticated in their understanding of things that we didn't have an understanding of when we were that age. And so some of it is for good and some of it is for bad. But I think that like people are, as younger people, they're much more aware of like their health needs and bodies. They're much more aware of their mental and emotional states too. I think that we've done a good job, I think, generationally, as we have gotten older, passing that down because older generations of people of color um, weren't really there yet, right? They were still reaching those places to start to pass it down. And then as we got older, it's almost like every generation, the information got closer and closer and closer and closer to the younger groups, right? And so the disparity around kind of at least an awareness, right? At least an insight into the fact that there's something going on that has changed significantly. And you can find out when you see that younger people are much more involved, even on like kind of community level, grassroots nonprofit organizations. You have much younger people in nowadays who really have a sense of what's going on. Now, in terms of like their ability to influence the system, I think for me, that's where you start to see the disparity because we as older professionals are actually in those systems, either working on the change and or working on the change and sending that information down the pipeline to the younger people who have it. And so the disparity isn't necessarily reflective of a bad thing. It's just that they're growing up into the system that, again, we go back to that idea, what is the status quo? We're creating a status quo that is to come, that these young people will enter into, right? And so that's where, to me, the real difference lies. And I think about myself when I look at other therapists of color. When I was like fresh out of graduate school, looking at the people who were maybe just starting their masters, just graduating undergrad, just getting into doctoral programs. I'm thinking to myself, I have to start to lay some of the foundation for them so that when they get out, the issues around mental health have already improved in terms of like the community level of awareness, right? And so to me, it's really the disparity is not necessarily an intellectual gap or an awareness gap. It's really just like we're just ahead of them. You know what I mean? Generationally, and actually putting into practice the things that we're all kind of learning about at the same time. We're generating the information they're consuming. That's the best way to put it.
Thank you so
Thank you
much
so much
for saying
for
that, because like that's really true.
true.
Because I'm saying we as if I'm much older than I am. I'm not, but like because I do think about that for myself, even at my age, right? That like there are certain things that we have to lay as a foundation for those to come. Like I think of like my sister who's 9 years younger than me, right? There are certain things that if I have the capability to do so at my age, or even when I get older, inshallah, that I have to lay a foundation for, right? Whether it's in public health, mental health, education, any of those things. I think that is very true because trying to build a foundation is the hard part, for sure. Like, it takes work, it takes, community. But I think once those foundations are built, it makes it easier for people to utilize them and not have the excuses of it not being there, right? Not have the excuses of like, well, we don't have this thing, so we can't do that, right? It's like, no, this thing is here. It's in front of your face. It's right here. Like, use it, right? And use it in a way that's going to benefit the community. So I want to segue this question over to Amoy. So what are the differences in our understanding of health, inequity, mental health from your generation and any generation that's younger than yours?
So it's interesting because I have a bunch of interns that are like 18 and 19, and when I talk to them, I don't know what they're talking about most of the time. I'm like, what? And I'm not that much older than them. I think one thing I always say about, what we see, and if we look at what the pattern of the changes that have happened in our society over socially, right? The social justice changes that have happened in our society, and the movement of young people. And from my generation, I am millennial. I'm a millennial, and then there's Gen Zs, I guess, that come after us. It's starting to come from a place of like, we're not going to take it anymore. Like, this is unacceptable. We have access to all this knowledge and all this resources. The Gen Z has literally grown up with the internet, and the fast one, not the one where the line goes. I remember AOL when it had to be dialing in, and I tried to sign in so my mom didn't hear me because I wasn't supposed to be on the internet, and then the noise comes. They have grown up with literally information at their fingertips. And I think that when you grow up with information at your fingertips, you do not take nonsense. You will not take there is no justification for why people do not have when other people have. And that is something to truly be admired. And that is something that even, let's say my generation, I guess, we're at the cusp. We are at the beginning of that because my generation is technically the generation that created social media. When I was in school, Facebook started when I was in college, and literally you could only get into Facebook if you had a school edu email. So my generation is the generation of social media. We started and the way that the next generation has taken off and run with it, they're just like, they are sharing information like crazy, and they are not tolerating nonsense. They are not tolerating disrespect. They're not tolerating cultural incompetence. They're not tolerating inequity. And in that, and they are waking everybody up to make sure that we all know that nobody is going to be tolerating this. Nobody should tolerate it. We're not going to tolerate the way we treat people with mental health issues, and we're going to talk about mental health issues. We're not going to hide it. We're not going to dismiss it. We're going to talk about it openly and candidly. I see it all the time when I, scroll through TikTok. It's amazing what Generation Z creates in 15 to 60 seconds. Literally, in 15 to 60 seconds, what they're able to create and the message that they're able to get out to millions of people, it is amazing. And that is extremely powerful. So when we talk about the understanding of health inequities, we're talking about the fact that we're a generation that's not going to deal with inequities anymore and going to say, this is unacceptable. We will not accept it. And everybody who is before us shouldn't accept it either. And that's a powerful thing. So really, really grateful to my generation for creating these tools for this younger generation for just taking these tools and running with it.
Yeah, I definitely agree on that. So I want to piggyback on basically on what everyone is saying. And I mean, as someone who does a lot of content creating and my own activism, I mean, Naja and I are the same age. So also from the millennial generation, having these being open, because when you look at older generations, it used to be the don't ask, don't tell. If you had mental illnesses, you wouldn't talk about it. You would have to ask your elders about, okay, what is our health history? Do we have this Do we have this running in the family? Do we have cancers running in the family? Is mental illness an issue in the family? Like, having to have these conversations is something that was a lot harder to do with older generations, unless they themselves have experienced it and have reached a point of enlightenment or just awareness. It's like, you know what, this is what it is. This is my story, or this is what I'm going through. However, when I'm looking at the younger generations, I'm just going to use my cousin in this case, who is 11 years younger than me. She finally told me that she has anxiety. So reluctant to tell me, and I said, you know what? We're going to have the talk, not the birds and bees, but more like mental health. Let's talk about mental health, as in, how often are you feeling these things? Do you know that this is normal? It's normalizing these kind of conversations is that what makes not just our generation, but the younger generations, and as well as the older ones, slowly but surely kind of understand the normality of it. And even if it's not being bluntly said in some situations, because some people just say, hey, I got this disorder, and this is what it looks like. Some people have used the arts, or have used, TikTok and different things and avenues to just talk about an issue without really blatantly talking about it, unless a conversation is being elicited. And I think that, yes, I definitely do agree with Amoy that definitely our generation is not trying to take any of that inequity anymore. And a lot of it is due to the fact that it's hit a point where it's suffocating. Like, we're basically being asphyxiated off of the sins of what system we currently have. Even though our previous generations are doing the damnedest to actually improve upon it, it's still the fact that something's got to give. And clearly, the groups that are feeling it and are basically trying to change it are trying to make it so that it is something so normal that it's not even taboo. Although ironically, we're doing a taboo let's talk right now about it.
Sorry, I'm still laughing. But no, that's true. Like, we have this event's called It's Taboo, Let's Talk, and it's talking literally about taboo topics, or topics that are just not talked about enough that it might as well be taboo, right? Cultural competence, vaccines, menstruation, mental health, substance abuse, all those different things are considered taboo topics. We talk about them, we don't really talk about it, right? It's not a common conversation. It's not a conversation that isn't. Sorry, my birds are very loud. They're getting as amped up as I am about this conversation. But everything it's very true. Like, you guys, throughout this whole entire talk, and I want to thank every single one of you guys for coming on here, taking out your time to talk about this, because it is super important, right? Cultural competence is involved in every single thing that we do, especially when it comes down to, because we talked a lot about mental health. We have a mental health specialist right here, aka Dr. Miriam Brockmary. I'm a hopeful, therapist to be, so I'm baby therapist right now. It's very important, because we talk about this a lot in my classes, right? Where if you need to understand where a person's coming from culturally. I'm inshallah, I'll be an art therapist, right? But if I don't understand where a person's coming from culturally, I might see something or interpret something that they're giving me as something else, when it might be a normalcy for them in their culture. And I might see it as like, oh no, like this is something really wrong, when it's not something that's wrong. So it's like, it is really important in the avenues that we take as we engage with other people, no matter what the profession is, whether you're working at a grocery store, McDonald's, politician, don't matter, anywhere in between, medical doctor, anything like that we are culturally competent in all of these avenues, because we interact with each other, right? And at the end of the day, we affect each other's lives, even if it might seem like it's the smallest thing possible. Siddiqa, you wanted to add something?
No, it's just amazing. And my daughter is actually sitting next to me, and she is like, oh my God, I can't believe they're talking about this. So and I think she would be a part of the Generation Z. So, but like you said, the difference in generations is incredible.
It's true. So I want to do before we go off, because we've been talking a while, but we've had a good conversation. A lot of times these conversations, they take a bit of time. So we did have a couple of comments from YouTube, actually, because we're on Facebook and YouTube. A few of them were from Stephanie Loreno. So I do want to just show it up on the screen. Boop, there we go. So this was kind of going back to the status quo question, right? So the question, so she answers, says, perhaps we contribute to the status quo by assuming we all operate on the same social norms, enforcing those points of view without respect to the life experiences of others. Right. And I see some nodding heads. I can read some lips saying, yeah, you know, and that speaks to some of the things you guys are saying, right? There's different ideas of what status quo is, but in a way it is kind of like that, right? It's the idea of what's socially normal, right? And in taking what's socially normal to us and not respecting other people's life experiences at the same time. Does anybody want to say anything about that? Because I have a couple. Yeah, go ahead, Dale.
Baby, can you hear me? Yes, being a baby boomer of the bunch here in generation, I want to jump on there and basically say we need to continue to have intergenerational conversations. I think that's key to have everybody on the line and to have intergenerational conversations. As far as the status quo, also, I do want to throw out that we have, due to the tragic loss in our community, the young man did commit suicide, and we just had his funeral recently. I'm not going to mention his name out of respect for the family, but in any case, we are starting a group called Community Healers. I'm inviting everybody here on this panel to join that group, Community Healers. So we're going to talk about mental health for real within our community. So I'm inviting, so I'd like, for you guys to jump on that, Community Healers. And we're going to tackle all the subject we're talking about, like I said, real life solutions. So that's basically what I want to say, because this young man's life was a tragedy. He was he's just in high school, 17 years old. So it's a young man. So we got to make this live. We got to make this real, as Dr. Caroline says, my pastor at First Central Baptist. We got to make this live. We're going to take this subject matter and then actually use it to make our community better. I'm going to stop right there.
Thank you so much, Minister Dale, for mentioning that, because that is true. Like, the more we are together, the more we can hopefully uplift each other and support each other, whether it's cultural competency or any other area where we need support. So wow, Stephanie said a lot of. You have a fan here, guys, because Stephanie said a lot of. She. I'm a pull up, watch, and then we'll have some closing remarks, because I know people are tired of seeing my face and hearing me talk sometimes. Okay, so another thing Stephanie said, it kind of came down to kind of like we were talking about with cultures and different experiences and how people are treated, right? So I certainly feel like, and I'm speaking from the experience as a Latinx, specifically an Afro-Latina, my community is not aware of the resources to prevent infection due to lack of access to the info. So I don't know if, Sadiq, if you want to touch upon that, to give some info on that stuff for the vaccine, or if Amoy wants to give anything, information, if anyone has it.
I think that's the case for a lot of communities, like specifically, one can speak to the Latin community. We're dealing with maybe a language barrier, different cultural barriers, different immigration barriers, depending on the community. We have to be on, like, the problem I find a lot of times is we have to be honest about the fact that everybody's success is inherent on everyone's success to a certain extent. And the fact of the matter is that, when we want to implement any type of policy and distribute resources, we're living in a society where resources are already inequitably distributed. So when you live in a society where resources are already inequitably distributed, the system that is created does not allow for equitable distribution of a resource that they want to equitably distribute, no matter how they try. So really looking at that and saying, how do we make sure to do the work of making sure and being extremely vocal and adamant about working with entities in these communities, in the Latin community, in the African community, in the Caribbean community, in the Asian community, in the Muslim community, making sure, how do we make sure that these communities get these resources? Well, it's by giving these communities more resources, by understanding that you have to, in essence, reallocate resources to make sure that communities get these services. And yes, it's something that is a huge problem, making sure that they get the education that they need, but really, really understanding that we're going to have to be reallocating resources to make sure that folks get the services and the resources that they need, because they have been generationally, they have been systemically ignored. And that is why we are in the circumstances that we're in, where Black and Brown communities have higher infection rates. So you have to reallocate resources to those communities to make sure that you get those situations under control.
Thank
And I
you.
just wanted to add one quick thing to that, which I agree with all of that, is that also it's a community conversation, right? So, you know, coming into a community being like, oh, you need 4,000 masks. Take them. It's like, oh, well, that's nice. Could we have some hand sanitizer too? So I think, you know, we want to oftentimes kind of just go in communities, and, you know, I saw this a lot in my life doing research, right? Is you just have people who look a certain kind of way, going into communities, doing stuff and patting themselves on the back and saying, you know, we did a good job. And the community's like, but that's not what we needed. We didn't ask for that. We didn't want that. Why did you bring that? We can't use it. It's going to go to waste. We need something else. So I would just say also that, you know, to Stephanie's fabulous points, and I see you, Stephanie, I see your multiple comments and they're amazing. To Stephanie's points, I think Stephanie might also be talking about, you know, sometimes you don't know what you don't know. And if you can't have a conversation with others, then you won't even be able to find out what you don't know. So we've got to, you know, be clear about that. And one just quick thing I want to say is pulse oximeters. Anybody heard about the study that involved people who were getting the you know, the pulse put on their fingers in the hospitals? And then study came to find out the studies have been done on primarily white individuals. They just don't really work that great on Black people. So when you go to the hospital and you get it clipped on, may not even be actually registering your right level oxygen. I mean, if you want to talk about inequities in health, those are the kind of things that just should make your blood boil and say, we've got to do better as a society, because that's outrageous. And in the era of COVID, where that's the difference between life and death. Do you know a person's oxygenation level? To think that we have in our hospitals right now machines that probably are not effectively figuring that out for Black and Brown individuals, we got to do better.
Wow. You guys are amazing. First and foremost, I got to say that snaps to everyone here. Let me take Stephanie's thing down. I want to say thank you one more time because we are closing. Unless somebody's like, nope, I got something to say. People need to hear it. The people need to know. You know, stop me right now. But all in all, I want to say thank you to our amazing panel for all the things you guys do in the community, because I see you. I don't see you now as much because, you know, outside kind of dangerous. But, you know, like I still see you and the things that you do, you know, for the community, you know, working with Missy, working with other community-based organizations, working in, you know, in areas of power to hopefully support and uplift the community in different ways. And I want to say a special thanks to, yay, thank you. I want to say a special thanks to Shay and Clarity for her amazing presentation, because she rocked that. She did a great job. She gave us a lot of statistics. Okay, statistics are important. As much as we hate doing the statistics, it's important when the statistics are done. First and foremost, I hate math, but I like what math can do. But I also want to say thank you to our amazing audience. Thank you so much, Stephanie, for commenting. Thank you so much for everyone for saying, you have a couple of fans too saying how amazing all of our panelists are and how great your words have spoken to them. And I hope everyone has a great night. I hope our audience has a great night. And thank you so much for joining us for It's Taboo, Let's Talk about cultural competency, health equity, and communities of color. Thank you, everyone. Bye.